For the objectives, nurses will be able to demonstrate the ability to perform appropriate assessments of patients with TBIs. They'll be able to verbalize understanding of the nursing management that takes place in care for a TBI patient and list 3 facts about ways to improve outcomes in patients with TBIs. Now let's look at an overview of traumatic brain injuries. Approximately 1.5 million TBIs occur every year in the United States alone. Of these injuries, 50,000 die and 1.1 million are treated for TBIs and then released from the hospital. This is the leading cause of death between the age of 1 to 44 years of age. Males ages 15 to 24 are more likely to have TBIs than any other group. Males are also twice as likely as females to have TBIs. The most common cause of a TBI is the motor vehicle accidents. Severe TBIs are defined on the glaucoma scale of 3 to 8. And the diagnosis is based on CT brain scans showing abnormalities such as hematomas, contusions, swelling, herniation, or compression.
Now let's turn to nursing management for TBIs. Some of the tasks that nurses can perform include maintaining adequate brain tissue oxygenation, maintaining arterial CO2 levels, monitoring for hypoventilation, assisting in secretion removal, and elevating the head of the bed 30 to 45 degrees. The following is an example of a clinical protocol nurses can use when caring for a patient with TBI. First, admit the patient to the trauma neuro ICU. Be familiar with and follow the standard ICU order set and TBI protocol orders for your unit or hospital. Place the patient on a monitor to measure his or her intracranial pressure. An intravenous catheter inserted following a ventriculostomy is the most accurate monitoring method. Administer prophylactic Dilantic intravenously. Additional protocol measures include intubating and mechanically ventilating the patient. Target PCO2 values are approximately 35. Prophylactic hyperventilation is discouraged. Place arterial line and pulmonary artery catheter. Optimize head position for lowest intracranial pressure values. Aggressively maintain normothermia. Use analgesia sedation as needed. Finally, manage blood pressure and intracranial pressure to maintain a cerebral perfusion pressure of 70 millimeters of mercury and an intracranial pressure of 20 millimeters of mercury. If these values are not met, provide the following steps sequentially. Drain the ventriculostomy. Increase analgesics and sedation. Infuse crystalloid to ensure intravascular volume is adequate. Administer neuromuscular blocking agent. Infuse mannitol as an intravenous bolus at 0.5 to 1 mg per kilogram and monitor serum osmolarity. This step can be repeated every 4 to 6 hours if osmolarity is less than 320. Nurses or the nursing staff should contact trauma and/or neurosurgery services if abnormal values persist or there is a major change in the patient's status. Finally, if patient has persistent intracranial hypertension and inadequate cerebral perfusion pressure, notify trauma and neurosurgery for initiation of phenobarbital coma. Consult neurology for dosing and continuous bedside EEG monitoring for burst suppression.
The severity of brain damage is best judged by the symptoms presented, a neuroassessment, the type of blow or injury, and the length of unconsciousness. Outward symptoms include bruising, halo sign, swelling, lacerations, hemiplegia on the opposite side of the hematoma, bleeding, unconsciousness, amnesia, headache, and a dilated pupil on the damaged side. Here you see the characteristic bruising of a patient with TBI. The raccoon eyes are signs of a periorbital fracture. Battle sign is bruising behind the ears, and a halo sign is found by dabbing fluid from the nose or ears onto a piece of gauze and waiting for it to separate. The CSF will form a ring around the blood, as seen in this picture. For the first 24 hours after a TBI, you will awaken the patient every 2 hours to make sure they are easily aroused. When you do arouse them, question their orientation by asking where they are, who they are, and so on. Check their pupils with a flashlight to check for perla, and monitor their neurostatus every hour using the Glasgow Coma Scale. To assess decreased level of consciousness in your patient, there are 6 characteristics you may note from their neuroassessment. Of course, the patients who are obtunded or stuporous are much more harder to arouse than those who are confused or lethargic. For the next 48 hours, make sure you report any signs of change of LOC, vision, speech, vomiting, dizziness, increased headache, and seizures to the physician so they can receive immediate treatment.
In 2016, the Brain Trauma Foundation published the 4th edition of the Guidelines for Management of Severe Traumatic Brain Injury. This guideline addresses treatment interventions, monitoring, and treatment thresholds that are specific to TBIs. The purpose of the guideline is to be used by others to develop treatment protocols and provide current evidence. These guidelines are a compilation of the 189 publications that are used for evidence in support of evidence-based practice. The guideline serves as both a systematic review and a synthesis of evidence, as well as a source of recommendations. Research was done to see how adherence to the Brain Trauma Foundation guidelines improved the patient outcomes. Adherence to protocols based on the BTF guidelines has shown to significantly decrease the length of patient stay for TBI patients that lived past the first 48 hours. It was also shown that following these guidelines decreased mortality and improved patient outcomes. It also reduced the financial resources used in the acute phase of the TBI treatment.
There are many treatment options currently being implemented for traumatic brain injury patients. However, the effectiveness and standardization of some of these treatments is still being researched. Ventilation therapies are commonplace for traumatic brain injury patients, and positive outcomes are seen. Patients with severe traumatic brain injuries require airway protection as they are at risk for pulmonary aspiration or compromised respiratory drive and function. Normoventilation is the goal for traumatic brain injury patients, and it prevents cerebral ischemia and cerebral infarction. Anesthetics, analgesics, and sedatives are important and commonly used therapies in acute traumatic brain injuries. They are used in prophylactic control of intracranial hypertension and seizures. While steroids have become a commonplace treatment for severe traumatic brain injuries, evidence shows little benefit for traumatic brain injury patients. In essence, they have no effect on patient outcome, good or bad. Proper nutrition is important in all patients, and traumatic brain injury patients are no different. Severe traumatic brain injuries are associated with increased energy expenditure early after injury. As with all patients, infection prophylactic treatment includes reduction of hospital-acquired infections. Severe traumatic brain injuries increase susceptibility to infection due to the need for mechanical ventilation. Traumatic brain injury patients are at a severe risk for developing venous thromboembolisms due to increased coagulation. DVTs can result in potentially fatal pulmonary embolisms. Acute symptomatic seizures may occur as a result of traumatic brain injuries. Administration of anticonvulsants following traumatic brain injury is used to reduce seizures. Monitoring itself does not directly affect outcomes, but instead guides the treatment of the patient. Informed treatment will result in better outcomes. Increased intracranial pressure is a problem for traumatic brain injury patients. Increased intracranial pressure causes injury and death to parts of the brain, and alleviating this pressure plays a pivotal role in good outcomes. Cerebral perfusion pressure is the pressure gradient driving cerebral blood flow. The homeostasis mechanisms of cerebral perfusion are often lost after traumatic brain injury, placing parts of the brain at risk for ischemia. Advanced cerebral monitoring consists of different monitoring techniques to determine brain tissue oxygen delivery, and the brain metabolism needs. This helps guide treatment for the patient.
When monitoring your patient, it is important to know the blood pressure, intracranial pressure, and cerebral perfusion pressure thresholds. For blood pressure, you want to maintain a systolic less than 100. However, it has been found that less than 110 may also improve outcomes in certain age groups. The ICP must be within a range of 0 to 10. Anything above 20 must be treated immediately to reduce the chance of mortality. And a target CPP should be between 60 and 70. It's recommended to avoid treating a CPP above 70 with fluids and pressors due to the high risk of respiratory failure.
Treatments in the hospital focus on improving brain tissue perfusion and decreasing intracranial pressure. After discharge, therapy focuses on reversing the complications of the traumatic brain injury. This includes improving quality of life and maximizing the independence level for the patient. The patient also needs to be aware of his or her own activity limitations. Therapy also focuses on improving cognitive functions, and realistic goals should be set.
Comorbid conditions related to TBIs include depression, PTSD, substance abuse, fatigue, chronic pain, and sleep disturbances. Pharmacological treatment and cognitive behavioral therapy are usually used to treat these conditions.
Patient education while admitted to the hospital. Do not allow patient to blow nose due to possible increase in intracranial pressure. Remind patients that they shouldn't change position without permission in order to prevent an increase in ICP. Provide education with family or responsible adult present. Multimodal education can include verbal, written, video, and audio instructions. It is recommended that instructions be given at a 6th to 7th grade level. Patient education upon discharge from the hospital. Follow treatment recommendations to aid recovery. Get plenty of sleep at night and rest during the day. Avoid physically demanding activities or those requiring extensive concentration. Avoid activities such as contact or recreational sports. Patients should ask their healthcare provider when to resume activities such as driving, bike riding, and operating heavy machinery. Avoid airplane travel initially, as it may worsen symptoms.